Good morning, everyone. My name is Talal Dahan. I'm one of the pulmonologists at Duke University. Through this short presentation, I plan to review a few facts about pulmonary embolism management. Those are disclosures I have. The objectives of this talk is to illustrate how important is pulmonary embolism, touch a little bit on clinical risk stratification, important investigations we need to consider, and also highlight some management options. Pulmonary embolism is defined as a clot that is found on CT angiogram of the chest with PE protocol or ventilation perfusion scan. Usually we assess right ventricular function by echocardiography to determine the significance of pulmonary embolism. This can happen by echo or through a CT scan of the chest. Blood pressure is what defines PE to be massive, submassive, or non-massive PE. And minor PE fortunately accounts for more than 2/3 of pulmonary embolism cases, while massive PE, where there is a mortality that can reach up to 50%, is only accounting for 2 to 3% of the PE population. We still have a reasonably high number of patients who present with submassive PE, which means enlargement of the right ventricle on CT scan or echo without hemodynamic effects of that. And they carry a mortality of about 7 to 21%, and you could see the variability on these patients as they could have a low risk or high risk to proceed with clinical deterioration. To touch a little bit on risk stratification, number of registries and databases went through that, and risk models have developed significantly to show that. The most important one that we have come across is the Pulmonary Embolism Severity Index, or the Simplified Pulmonary Embolism Severity Index. Ojeski from Switzerland was able to define that through a paper in the Blue Journal back in 2005, while David Jimenez from Spain was able to summarize or simplify the PE risk score to be more useful and valuable for a clinical use. Those are the parameters of both. The simplified PESI paper was able to compare both, where we see age remains an important factor for both risk stratifications. The presence of cardiopulmonary disease illustrated another important point, and then other clinical findings of tachycardia, hypotension, and hypoxemia at baseline were thought to be significant factors. What was really helpful through the study that the original PESI was mimicked through the simplified PESI with similar ROC or ROC curve presentation, and the positive and negative likelihood ratios were actually thought to be better for the simple risk stratification score. Therefore, we would generate a better positive likelihood ratio and also a better negative likelihood ratio to use that score for predicting outcomes for patients who are presenting with PE. So it's important to calculate the simplified PESI score when we look at these patients. The next step is really to look into what other investigations we need to consider. And this paper by David Jimenez, and it included Victapson and Sanchez from United States and also Spain, where it looked into about 848 normotensive patients with acute PE, so patients who really had stable blood pressure on presentation, and those with troponin leak, pro-BNP rise, the presence of DVT by ultrasound, and also having a simplified PESI of more than 0, which means it was positive. Those are the patients who did worse with time. The next step is really to look into the value of CT angiogram for the diagnosis and management of patients with PE, and this is the original paper that looked into CT angiogram with multi-detector sensors, and Victapson was part of the study when he was at Duke University. the paper illustrated the importance of the positive and negative likelihood ratios of CT angiogram, and that positive and negative LR would increase significantly if we include a CT venogram with that as well. CT angiogram of the chest is not only helpful to diagnose PE, it is also helpful to address the right ventricular to left ventricular ratio, as we can see here, and this is usually calculated by 1 centimeter below the annulus of the right ventricle and the left ventricle. It can show you the early septal bowing. It can also show significant septum bowing on the left ventricle. Subdiaphragmatic clots can be easily seen as well. The presence of a scary saddle clot like that would indicate further evaluation and careful look for patients, and it can also detect linear clots like these where ventilation perfusions can miss them over time, and here comes the importance of such a study to be considered. This is not to decrease the value of echocardiography, and this is a 4-chamber apical view of the heart for a patient who presented with non-massive PE. You can see that the left ventricle here is happy and the right ventricle is not dilated at all. And if you add this picture in mind, you would see how the right ventricle is significantly dilated and affected, and it's causing significant compression on the left ventricle, with significant dilation on the right ventricle here and significant compromise on the left atrium as well. Keep in mind that echo is also important to show you if there are any clots in transit, and this is a huge and significant clot in transit that is causing significant compromise for this particular patient. And it's important to keep in mind that clots in transit are indicating an aggressive surgical intervention that we should always to keep in mind. And it should scare you when we see it for sure. Those are additional investigations that you may consider for patients with pulmonary embolism on the echocardiography, where some objective parameters can be assessed and obtained for these particular patients. Management options. This is to illustrate that we are still focusing more on anticoagulation. There are conditions where systemic thrombolysis have to be kept in mind. It's emerging over time to consider catheter-directed interventions, and surgical embolectomy is particularly useful if you use or end up maybe not using all the other investigations that are kept in mind. Anticoagulation is not as simple as we think, since heparin infusion can be considered and low molecular weight heparin can be considered as well. Direct oral anticoagulants are rising for non-massive PE management or whenever the patient is ready for a discharge home, and they are actually recommended over low molecular weight heparin and vitamin K antagonists such as warfarin. Systemic thrombolysis, whether it's full dose or half dose, is a debatable topic to be kept in mind. Catheter-directed interventions are so many, and I'll go through them briefly in the next few slides. This is the landmark study indicating that thrombolysis is something that we're not going to discuss again in massive PE patients who are hemodynamically unstable, patients who do not receive TPA and they are on inotropic agents or hypotensive are not going to do very well. While those patients who develop submassive physiology are not expected to benefit as much from systemic thrombolysis at full dosage, where the number needed to treat to minimize their death or compromise was 33, with unfortunately a higher number needed to harm, where 20 patients developed major extracranial bleed and 47 patients ended up having a stroke. 47 patients received systemic thrombolysis and one of them ended up having a stroke, which is a catastrophe for patients with PE management. This is another meta-analysis that looked into how much major bleeding events we have when we administer systemic thrombolysis for management of pulmonary embolism with submassive physiology, and almost all the studies indicate a number needed to harm that is significantly more than the number needed to treat, which makes us sway away from full dose systemic thrombolysis, but there are still considerations for half dose systemic thrombolysis, although the evidence is not strongly conducted in that manner. Catheter-directed interventions are so many, and this is a slide that I borrowed from Dr. Tapson and Cedars, and he showed us how significantly emerging number of catheters are being used for PE management as we go through assessing these patients. And selecting the right catheter can be a challenge. Angiovac devices are coming into place with significant help. Vacuum-assisted thrombectomy is another name for them. There are only case series for these kind of devices. They have significant black box warning for PA arrest, and they require as well extracorporeal life support to minimize that. So they are usually useful in the right setting. This is a patient that I have seen with sudden shortness of breath with recent cervical spine surgery, and echocardiography showed a clot in transit in the right atrium that is almost causing cardiac arrest, and with angiovac and extracorporeal life support, we ended up extracting such a big clot that was almost causing cardiac arrest for this patient. This is an example of a device that we use significantly over the last 2 to 3 years. It's called the Echosonic Endovascular System, or ECOS catheter, where it basically incorporates having an ultrasound core beam catheter that is inserted in both pulmonary artery branches with an infusion catheter that is in place, and they are usually placed in both pulmonary arteries. The concept behind using that was addressed many years ago, where ultrasound was found to cause significant loosening of the clots by itself, and with small doses of TPA we may end up having those small fibrin clots dissolve as well as quick as possible to minimize the strain on the right ventricle. This is how the catheters are placed under fluoroscopy guidance, and then this is how the infusion catheters are placed as well, with fluoroscopy image at the end of the procedure. This is the first randomized study that showed significant improvement of the right ventricular to left ventricular ratio, suggesting hemodynamic benefit, but there was no significant mortality or morbidity benefit between both groups who received this catheter intervention or just anticoagulation. Larger registries showed that this catheter is actually safe and can be considered for massive PE patients where the risk of intracranial bleeding was as low as 0%, with significant benefit of the resolution of right ventricular strain with improvement of RV to LV ratio. The perfect study was a nice study that shows not necessarily ECOS catheter is what we should look for, where the institutional comfort and the operational interventionalist is what determines the right thing to be done. And this study showed no major procedure-related complications, hemorrhages, or hemorrhagic strokes, and all had significant improvement of right-sided heart strain with mechanical or pharmacomechanical catheter-directed interventions with or without small doses of thrombolytics. Optolized PE study is an important study that made us become aware that despite improvement in clot size and RV size with smaller TPA doses, we started having a higher risk of bleeding, which makes us think twice before we proceed for these procedures. Rescue thrombolysis is another question that we ask. Why shouldn't we proceed with TPA when the patient starts to deteriorate instead of trying to administer TPA and they don't do as well? Rescue TPA in cardiac arrest thought to be from PE did not work, and this is data from our institution that shows no effective intervention with TPA during PA arrest of suspected PE cases to achieve return of spontaneous circulation. Therefore, guidelines are all in favor of proceeding with aggressive interventions when there is shock from PE, anticoagulation, and perhaps discharging patients home when they are deemed to have non-massive low-risk PE according to the Simplified Pulmonary Embolism Severity Index. And the debate comes when we reach a clinical situation where there is an intermediate high-risk PE with intermediate low-risk PE, and what defines that both have right ventricular enlargement as assessed by CT scan or echo, and then elevation of cardiac biomarkers or stretch markers such as proBNP, in addition to the enlarged right heart by imaging, would indicate a high-risk clinical condition that deserves further monitoring in an ICU setting and activation of what we call a PE response team, and that will be helpful to determine the next step of management. This is why PE response team is important. It's an organization that worked hardly. It's non-for-profit organization to bring multidisciplinary caring teams to discuss pulmonary embolism management, and it is really helpful to keep us up to date. Thankfully, Duke University is a founding institution for this great organization, and the PE response team is basically an easy access of multidisciplinary consultative services that come together to discuss a case in a very rapid fashion, an evaluation kind of maneuver. It's usually achieving a diagnostic plan, and it also arranges for steps and interventions for the next step afterwards. The key for this success is to have motivation. There is an algorithm for PE management that you may already have seen. It usually indicates a great learning experience for trainees. It utilizes available specialties. There is usually a common pager or call, that's pulmonary vascular disease here, or MICU or CCU to illustrate more active and rapid initiation of this important team. It is usually of a collaborative decision to come together on how we proceed. PERT members, as you can see, can be so many people, and they don't have all to come together for a decision about these population of patients, while if they are all coming together for a discussion, it might be a good idea. It can be tiring. However, what was found through literature that forming PERT teams resulted in less unnecessary thrombolysis, better monitoring for patients, especially if you consider seeing them as outpatient, and also important utilization of resources. This is our fabulous Duke committee that came together to form the PE management algorithm that you guys can access through the consult to pulmonary vascular disease through Maestro Care. This is another way of accessing the pulmonary embolism response team, as well as accessing the protocol for management, where the QR code below will send you to the agreed upon protocol that we use for managing these patients. Pulmonary embolism is a complex disease. Risk stratification is needed. Sometimes it needs more than just a simple decision. Without interprofessional approach, we may lose patients, and keep this always in mind. Thank you very much.